Should mention Mark Schickendance, team physician for Cleveland Indians, couldn't make it because of the World Series last night, so I've been pinch hitting for him a little bit. The thrower and the pitcher get so much attention, but the batter also has significant problems that challenge us, and almost always it's well, not almost always, but frequently it's a posterior instability pattern. Posterior instability, the shoulder going out the back, is much different than anterior instability, much less common. It's only about 10% of all the instability patterns. And when it comes out, it often doesn't require that relocation in the emergency room. Usually goes back into the joint on its own. And it usually develops insidiously. It happens over time. It's not a single traumatic event. And it's this type of mechanism. It's axial load with the arm in adduction and forward flexion. So football linemen get it all the time. Pitchers get it when they go through the follow-through phase of throwing. And the hitter gets it. And the hitter has kinetic chain energy features just like a thrower. They develop all this kinetic energy and then they transfer it to the bat and attempt to really crush the ball. So during this acceleration phase of throwing where you're driving forward, you're uncoiling, you have this tremendous posterior directed force, 500 pounds on the glenohumeral joint, and the humerus is in adduction and internal rotation. So this is a setup for that posterior instability. And in fact, certain pitches create more adduction, outside pitches, so those are going to be more of a problem than inside pitches. And then swing and miss. You swing and you miss, and you don't have any energy transfer to the ball. There's going to be more energy that goes through the glenohumeral joints, so those are going to be a problem. So posterior shoulder pain that occurs with hitting is typically related to posterior labrum and posterior instability. And players will even say it's these outside pitches that I can't get to, or when I swing and miss, that's when I feel it. Now we're going to go over some more examination maneuvers. I left these out of the other physical exam because we were going to show them here, but here we're going to do that load and shift. We showed this before. We're going to see how far the ball translates posteriorly. And then we're going to do this posterior apprehension, and we're going to simulate the position of instability. So adduction and internal rotation, and then we're going to apply that posterior force. And they'll complain of pain with that, and it reproduces what they feel when they're swinging. Now we can do, this is almost like a pivot shift. This is load and shift here, but the jerk test is like a pivot shift of the knee. We can force the shoulder out, and then when we bring it back to a neutral position, it'll reduce and you'll feel a palpable clunk. So that's called the jerk test. Very similar to what we did before, and it's much easier to do, as you can tell, with the patient under anesthesia. This is the Kim test. It's just modification, a lot of modifications to these tests where the arm is in more of a forward flex position. So this is a patient who can voluntarily pop his shoulder out the back. He's happy to show me. And here's what the MRI scan looks like that Mike just showed us. MRI, posterior labral tear. The pathology is typically in the back and the x-rays are normal. Here's some even cartilage damage related to it in the back of the shoulder. Okay, the treatment's typically non-operative is first. There's going to be seasonal career timing and things like that, but we rest them, we get them strong again, and then we go through a progressive hitting program, much like we do a progressive throwing program for a pitcher. If they fail this, then of course there's an opportunity to correct them with surgery. So the surgery for this is arthroscopic. We're going to see some of these different techniques throughout the day. This is a shoulder where the patient's lying on his side. This is the front of the shoulder, this is the back, so we're going to make portals to be able to visualize the pathology. This is viewing from the back, and you can see the labrum doesn't look that great. This is now I put the camera in the front, socket on bottom, ball on top, patients lying on their side. This is now a probe, and we'll see if we can, let's go to the next slide and see if that shows, because we'll see it from here. Okay, so now we're viewing from the front. Okay, good. So we're going to, this is a big tear. See this? Back of the shoulder is all labrum. It's all torn. We're going to abrade it to stimulate it to heal. And then we're going to put in some suture anchors. And we do that percutaneously. This is the rotator cuff over here and the capsule that we're going through. And we're going to repair this by putting anchors and putting sutures in place. This is the typical repair. Here's a big knot over here. This knot is near cartilage. We talked about marcaine and anesthetics ruining cartilage. We've seen this a number of times now. When we put sutures inside and tie knots, if it makes contact with the cartilage, you see we're getting a erosion here on the humeral head related to its contact with the knots here. This has become a significant problem. So our technique has evolved for fixing these, where now we prefer to avoid knots. So we have constructs and techniques where we can place anchors and place sutures without having to use knots. We always stimulate healing. I'm showing a little strategy to get a shaver inside to stimulate the bone in order to get it to heal. So we're shaving it and irritating it right at the repair site. And then we're going to pass suture, and this particular suture is flat. We call it tape. Call it labral tape. Fix the labrum with it. And then we're going to use that labral tape and we're going to put it into a drilled socket with an implant, and there's going to be a fixation of this tape that does not require knot tying. It's sort of a friction interference fixation. So when we put these in and we're all done, and we'll put multiple in, we're going to see something like this. You guys can't see it, right? That's what we like. So there's these labral tapes right here that are fixing the labrum, and you can barely see them, and we don't have knots here. So it's something that's going to be less traumatic to the shoulder. So typical rehabilitation and mobilization, get motion back, then we get strength back. Here's something to know. 4 months is when they begin a hitting program. It's typically 5 to 6 months before they're returned. This is a global study by Jim Bradley on a large number of patients that is prospective. The results are pretty good. These aren't isolated hitters, but in general, posterior labral repair is pretty satisfying. That's the adduction problem. I'm just going to finish that. We see this too, and Tony's going to talk about anterior problems, but that's in the initiation of the swing and the follow-through. You get this great external rotation and abduction that causes more of an anterior problem to the shoulder. That's not what we were addressing here. Thanks so much.